Welcome to The Explainer. Today, we're diving into a word you've definitely heard before, shock. But we're not talking about a surprise party. We're talking about a critical medical emergency where the body's entire system is right on the edge of a total collapse. It is a frantic race against the clock, and honestly, understanding what's happening can be the difference between life and death. I want to start with this quote from surgical literature because it's just so stark. This isn't an exaggeration for effect, it's a clinical reality. It really frames the high stakes we're talking about and why getting a handle on this condition is so important. So, what exactly is medical shock? Again, let's just throw out the idea of emotional surprise. In medicine, shock is a massive, body-wide physical crisis, and at its very heart, it's a catastrophic failure of flow.
Okay, that sounds pretty technical, right? But let's break it down. Low tissue perfusion is just a fancy way of saying not enough blood is getting to your tissues. And when that happens, your cells can't do their most basic job, breathe. They are literally being starved of the oxygen and the fuel they need to live.
Now, let's zoom in and watch what happens to just one single cell as this crisis unfolds. First, no oxygen. The cell panics and switches to this desperate, inefficient backup power. The problem? This backup process churns out a toxic waste product, lactic acid. As that acid builds up, the cell's internal pumps fail. It starts to swell up like a balloon. And then it bursts. And when it dies, it releases all these harmful chemicals that just start poisoning its neighbors. It is a deadly chain reaction at the microscopic level.
So imagine that cellular crisis happening to millions and millions of cells all at once, all over the body. That's what triggers a system-wide state of emergency. Your body pulls every single alarm lever it has, putting the entire system under siege. And here's that all-out emergency response. Your heart starts racing, your blood vessels clamp down. It's all a frantic attempt to redirect blood to the most important places, your brain and your heart. You start breathing faster, trying to literally blow off the acid that's building up in your blood. Your kidneys slam the brakes on making urine to save every last drop of fluid. It's a desperate last-ditch effort for survival.
So, it turned out shock isn't just one single thing. It's broken down into 4 main types, all based on what started the crisis. Now, here's the key thing to notice on this table. For the first 3, the problem is low cardiac output. The heart just isn't pumping enough blood. But in that last one, distributive shock, the heart might be working overtime. The problem is the blood vessels have become so leaky and wide open that the pressure just vanishes. Knowing which type you're dealing with is absolutely crucial because the treatment is completely different. But here's what makes shock so incredibly dangerous. A patient's vital signs, their blood pressure, their heart rate, they might actually look pretty normal for a while. That's because the body is compensating so fiercely. But beneath that calm-looking surface, something called occult hypoperfusion is happening. The gut, the muscles, the skin, they're still being starved of blood. It's a silent, hidden buildup of damage.
And this is why that hidden state is so terrifying. It's a ticking time bomb. If a patient stays in that state of occult hypoperfusion for more than 12 hours, their risk of dying can double or even triple. The damage just becomes irreversible. So how in the world do doctors fight back against this? The goal isn't just to treat the symptoms, it's to go right to the source and restore that flow of blood, to pull the patient back from the brink. The very first, most urgent step is to fix the volume problem. You've got to refill the tank, so to speak. Doctors use big IVs to just pour fluids back into the circulatory system. You have to give the heart something to pump. This is what they mean when they talk about fixing an inadequate preload, giving the pump enough fuel to do its job. Now, this is actually pretty clever. Doctors use that first blast of fluid as a diagnostic tool. By giving a quick fluid challenge, they can see how the body responds. If the patient's vitals get better for a minute but then start to fade again, they're a transient responder. That probably means there's some ongoing bleeding. But if there's no improvement at all, they're a non-responder, and that is a massive red flag for a catastrophic, uncontrolled bleed that has to be stopped right now. And that leads us to the most extreme cases, like major trauma. In these situations, just pouring in fluids is like trying to fill a bucket that has a giant hole in the bottom. You have to stop the leak. Severe bleeding triggers this perfect storm of awfulness known as the lethal triad. The shock itself causes acid to build up in the blood, which stops it from clotting. At the same time, the patient gets cold from the blood loss and from all the IV fluids, which also stops blood from clotting.
And of course, when the clotting fails, the patient bleeds more, which makes the acid and the cold even worse. It's this vicious downward spiral where every problem just feeds the others. Realizing this lethal triad was happening led to a total paradigm shift in trauma care. It's called damage control resuscitation, and the whole focus is on breaking that cycle. So doctors now intentionally keep a patient's blood pressure a bit lower than normal. It's called permissive hypotension, so they don't blow fresh clots off the injuries. They limit the clear fluids so they don't dilute the blood's own clotting factors. And surgery becomes this mad dash to just stop the bleeding and plug the holes, leaving the complex repairs for later, once the patient is stable. But even when a patient is pulled back from the brink, even when the bleeding stops, the fight is far from over. Surviving the initial shock can come at a really steep price.
The damage done during that time of low blood flow, and then, ironically, from the rush of blood back into those tissues, can lead to multiple organ failure. It's a devastating complication where the lungs, the kidneys, and other organs just start shutting down one after another, and the mortality rate is a staggering 60%.
To try and prevent that organ failure and treat major bleeding, doctors turn to their ultimate tool, blood transfusion. At the end of the day, the best replacement for lost blood is blood. But it's not a perfect fix. Donor blood is a precious, limited resource, and it comes with its own set of risks, from immune reactions to infections. And man, the journey to make transfusions as safe as they are today has been a long and wild ride. I mean, from early disastrous experiments with animal blood to the very first success in 1818, all the way to the landmark discoveries of the ABO and rhesus blood groups that finally made it a reliable, life-saving procedure. And that really leaves us with a final, fascinating question. With all the challenges and risks that come with donor blood, could technology one day give us a better, safer alternative? Could we actually create synthetic oxygen carriers that completely eliminate the need for a human donor? That could revolutionize how we treat the most critically ill people on the planet, and that is the next frontier.